or
Forgot to do
oh, okay.
All right, go
I was
ahead.
wondering about, I was just going to ask that when Amy, yeah.
Yeah. So
That's so fascinating because, you know, I guess, Sally, I just found out that you've been sitting in on my course. And so you're preaching to the converted, right?
Yeah.
Like
yeah.
I'm teaching those basic things that everyone can do. And when I talk to physicians, I give them the same message. Like, you don't need to be some super specialized expert. You just have to use common sense.
Right.
And very simple education and support strategies for patients that every doctor should know.
Right.
Whether they do, that's a different matter.
And your response, like you've mentioned, when you do your surveys, your response is overwhelmingly positive and grateful for the information. It's not like saying like, oh, this wasn't adequate, you didn't give me anything.
Nobody said that. I've been doing it for a year and a half.
Yeah, they're incredibly thankful for this basic, just nobody's doing this stuff.
Yeah.
So, well, let me start. Should we start with the
you know what, I wanted to let Tatiana introduce herself.
Yeah.
Because she and the patient partners whom she represents on our team are playing a really critical role. Go ahead, Tatiana.
So my name is Tatyana Kuzman, and I am a retired nurse. I actually worked a couple of years in hospital on different units, and then switched to public health nursing, where I thought community-based programs were more appropriate in so many ways. So Amy, I hear you. And I did that for a couple of decades. Then due to chronic illness, I stopped that and reevaluated my life, focused on my aged parents, and then went back to university, and I got a certificate in a specific type of qualitative research. So it is called PACER. It's Patient and Community Engagement Research. And it really focuses on patient-led research from the onset, like from thinking of what's the research question, co-designing the entire research study. And now I'm actually one of the teaching assistants for that program, because I can wear my nursing hat and I can wear a patient hat. I do not have ME. I had issues with fibromyalgia and with chemical sensitivities, and Lyme disease. Anyways, so that's kind of my story. And I got involved with this study dealing with DNRS because I was amazed at how my life stopped when I was diagnosed with multiple chemical sensitivities. I mean, environmental sensitivity, like I could not work. And just by serendipity, I heard about this DNRS program. And throughout my nursing career, I always had issues with the healthcare system pushing drugs to solve things, as opposed to having people develop self-care skills. And I thought this sounded very promising. It's a brain retraining program, and it doesn't focus on drugs. So you don't have to get any involvement from pharmaceutical companies. And I thought, yeah, I would try it. I took the program. I took a 5-day intensive program, and it was an excellent program. Now, in terms of the results that I can say from that particular cohort that I was part of, the ones who seemed to be cured from their standpoint of view were the ones who were the youngest and had fewer issues. So I would use the analogy of an onion. You've got several layers of an onion. And I think in my case, I have probably several layers that have to be peeled and retrained. Chronic back pain, this, that, whatever. Whereas perhaps a younger person or an individual who at whatever stage of life has only one issue, perhaps they can focus all that energy from this brain retraining program. And they're like 6 pillars in this brain retraining program that they ask participants to really work at. And I think it's important for all aspects of those pillars to be considered by anybody who's taking this retraining program. Anyways, so I'm one of 4 patient partners. We all have either ME or environmental sensitivities. I think, I don't know if any of us have fibromyalgia per se, but those are the 3 diseases that we're researching. And we have been involved since the very beginning. And so we are at the research table, we are at the meetings that we have, not necessarily monthly, but as necessary. And sometimes we are very, very busy for a couple of months, and then things slow down, and then it picks up again. And especially the patient partners who have ME, they can really add the patient perspective, because they are the ones who are checking the Facebook and all the online community platforms and coming back and saying to the rest of the research team, to the physicians, to the PhDs in research, saying, but hold on, this is what the patient community is saying. So we're not coming in just with our own personal perspectives of our conditions, but we're bringing in the perspectives of a broader community. So, and all of us, I would say, are extremely well educated, which I don't necessarily think you have to have that. I think sometimes it's good to have a variety. Just looking at my involvement with the university in the PACER program, but in this context, it really is a necessity because of the type of material we're reviewing. And we're very well supported by the rest of the research team. They hear us.
Thank you.
And Ellie's amazing.
Well, that's a good segue. So let's,
Okay.
can I do an introduction for you?
Sure. And
Dr.
then
Stein?
after you do that, I want to kind of give you the context of this study that we're going to talk about, because this study is just one small part of a bigger endeavor.
Okay. Yeah,
Yeah.
we'd love to hear what the whole picture looks like, because that's, I guess, we don't want to overlook what you guys are working on. So just a brief summary of all the things that you have done. Dr. Stein specializes, first of all, you're in Canada, correct?
Correct. Calgary.
Calgary. Okay, so specializes in psychiatry. In her practice is dedicated to MECFS and fibromyalgia, MCS, mast cell or multiple chemical sensitivity, and ES patients. She is focused on the role of neuroplasticity in managing these conditions. You are a recipient of the Florence Nightingale Award from Edmonton ME Association and was a signatory of the open letter to the Lancet regarding the PACE trial. So thank you very much for participating in that. You are the creator and facilitator of Pathways to Improvement, an online program using neuroplasticity concepts for those with MECFS, fibromyalgia, and ES. You document chronic fatigue syndrome, an assessment and treatment of patients with ME. Clinical Guidelines for Psychiatrists was published in 2005. is considered a seminal document in understanding the difference between ME and psychiatric diagnoses. So welcome to this Zoom platform, and we really look forward to hearing your activity, what you've been up to.
Okay, thanks, Amy. I'll just make one small correction. Actually, I'm interested in neuroplasticity, but what I do in my practice and what I teach in my online course is self-management, and neuroplasticity, I would say, doesn't even figure that prominently. But just to say, I'm hoping in January, when my very exciting trip to the Antarctic was canceled due to COVID, I'm going to develop a new online course, and it will be very focused on neuroplasticity. So I am super excited about it, but actually my practice, I wouldn't want people to get the idea that's what I do, because it's very broad. So I'll just give you a little bit of background of the research team that ended up publishing this systematic review. Tatiana, do you remember when we came in, like how many years we've been together? Is it like 5 years? Feels like a while. We've been moving at what for me is feeling like a frustratingly slow pace.
This is the 5th year.
5th year, okay. So how it happened is one of our patient partners did the DNRS program, Dynamic Neural Retraining System. We'll talk a little bit more, and had a really good result. And she happens to be personal friends with the person who at that time was like the Dean of Research at the medical school in Calgary. So she was talking to him, and he could see how much she had improved, and she had severe ME and many comorbidities, and nothing else had worked up until that point. And so he got kind of excited seeing the change in her, and he helped us approach the faculty. And at that time, sorry, I'm blanking on her name or what her position was. I might need your help, Tatiana.
Sunita?
Huh?
Are you referring to Sunita?
No, the woman from the faculty who kind of got us moving, who has since passed away.
Oh.
Anyway, we got connected at the highest level, let's just say. And what was so exciting is everybody bought in without, like, there was no questioning, or does ME really exist, or FM is, you know, for means you're lazy. Like, there was just none of that. They just took everything we brought to them at face value. Then it's going to come to me hopefully before the end of our time, but this woman who is amazing got us connected with Sunita Vora, who is and again, we have funding cuts in Canada, especially in Alberta. So her institute got canceled, no longer exists, but she was the head of an institute at the University of Alberta on integrative and complementary medicine. So she has that's her career, is to study, you know, you would say non-pharmacological interventions, basically. So Sunita is really you would say our principal investigator, because she's the one with the PhD and the, you know, the research expertise. And then she brought on board Salima Punja, who is her postdoc, and then Samana Ardestani, the first author, who was her PhD student at the time. So Sunita is very meticulous, let's say. There's pros and cons to that approach. The pros are I feel like we've done everything really carefully and correctly, and we're slowly building towards doing a study. So she advised us that the first step in doing a study is to see what's already out there in the literature, and that's where these systematic reviews come in. So we actually completed 3 of them, one for MECFS, one for fibromyalgia, and one for MCS. This is the first one that came to press. The MCS one just got turned down, so we're looking to submit it to a different journal, sorry. And the fibromyalgia one, unfortunately, the lead author, who was Karen Olson's, I don't know, master's or PhD student, she got a serious health condition. And so that one's kind of on a little bit on hold at the moment. So our goal in the systematic reviews was basically to search for, interpret, and report on what's in the literature to date. And I think that approach, as we go through some of your questions, hopefully that context will be helpful, because we basically have to report what's ever there, you know, and obviously what we found is there's huge gaps and limitations in the literature, which I'm sure is what you're going to ask us about. So I'd be happy to answer any questions that you have.
Well, I guess my my first question is, I mean, I from reading, what criteria did you find most useful, helpful? What diagnostic criteria? How did you find the ME patients? And that piece of it is, I guess, what often is the most criticized with articles is, you know, what kind of pool, who are you measuring, and what are their criteria? And did you look at post-exertional malaise specifically, or not at all? Or what, can you just talk to that piece of it?
Sure. So and again, I'm not the researcher, right? I'm the clinician. So I hope Tatiana can jump in, please, if you think I've got something a bit backwards. So when you're doing a systematic review, if you look at the paper, which I've got pulled up, I'm not sharing my screen, but just, you know, so it's in front of me. On page 4, we have all the criteria for selecting studies. So it tells you what we searched for. And we tried to search for everything we could think of as broadly as possible, because I'm very familiar with the literature. I've read thousands and thousands of papers, so I knew there was like almost nothing. So if we had limited, so say for example, so at first we took every paper. So if you look at the part on page, page 6, where it shows how we went through the process of looking for the papers that we were reviewing. So with those search terms, we identified 380 papers. Every single one of them was searched like by hand, right, and read. So our team read the papers. I guess they read 270 of them to see if they actually were studying people with MECFS, and were they actually studying a mind-body therapy. So you can see that 223 of them weren't relevant. So that meant either it wasn't MECFS, or maybe it was fatigue, for example. So there's a lot of papers out there on fatigue or chronic fatigue, so we didn't include those. Or it wasn't a mind-body therapy, or it wasn't a controlled trial. So we only included studies where there was an actual intervention, they were measuring it before and after, and there was some kind of, trying to think now if there was a comparison group or not. Yes, we only took studies where there was a control group. So it just kept getting pared down and down and down, because most of the studies didn't meet those incredibly broad basic criteria. And so we came into 47 studies that were potential candidates, but then you'll see that 29 were excluded because they were only a case study, like they weren't even a group of people. And of course, a case study for this purpose isn't very strong evidence. And then some more weren't the population of interest. So when we actually read it, it wasn't about MECFS. There was no control group. The intervention wasn't a mind-body therapy. So for example, you know, there's many, many decisions. We made the decision not to include CBT because we feel it's a more conventional psychological therapy and not a mind-body therapy. So we were really trying to look at what evidence is there, and I can't remember our definition of mind-body, but it's something like you're doing a treatment on the mind and you're measuring outcomes on the body. I think that was like our basic definition. So basically, we got down to only 12 studies, and we haven't even yet looked at your two questions. How did we define ME, or did we look for PEM? So that was only 12 studies that actually included MECFS and included a mind-body intervention, was an actual treatment trial of like more than one person, and had a control group. Of those 12 studies, if you look through the very detailed list of everything, you'll see that two of them, so the diagnostic criteria were different. And so in the discussion section, we discuss that and say, so the ideal strategy is to do a meta-analysis, which means that you take a bunch of studies that use the same criteria and the same outcome measures, which are quantifiable, and you see whether grouping them all together, there's an overall trend towards the intervention working or not. We couldn't do that because all the studies had different interventions and different diagnostic criteria and different outcome measures. So that's why we chose a systematic review as our kind of strategy. What we had extensive discussions, mostly including me, about whether we should include the two studies by Suroway and Rhymes that even mentioned the Oxford criteria. And we decided the pool was so small that we should mention them, but then say the limitations of the Oxford, which we did in the discussion section. Not a single study measured post-exertional malaise. So it's not our selection. We selected every single study with every single outcome measure, and it just shows how poor the research is, that not a single research team included PEM. So if we had only included studies with PEM as an outcome, we wouldn't have been able to publish anything. So we made the decision it would be better to read and again interpret and report on the literature as it is, as a starting point. So for us, we're now at the stage of our collaboration where we're applying for research funding to actually do a study of our own, which does include PEM and which uses the Canadian consensus criteria only. But if we hadn't done these systematic reviews, we would be we're in a weak position anyway, because again, there's not like millions of dollars out there for MECFS research. But if we had chosen to be very, I guess, limiting to say studies that only included the PEM, then we wouldn't have been able to publish anything, and we wouldn't have had that as a support for our current stage, which is to apply for funding. So that's quite a long answer, but it's a really good, important question. Oh, Sally, you're muted.
I really appreciate that, because I think that's really thorough and helps me understand, because certainly not being a researcher, we did any one semester research project, but
me too. I didn't even do one semester, so
yeah.
This is a steep learning curve.
Yeah, and my remembrance and the little bit I've done since of reading about research and stuff was that a systematic review is like a question is established and then go from there. And that was one of the things I think that in the discussion that came up about this was, why weren't the parameters set more succinctly so that and I think there's, now I'm hearing the validity or the value of having these in there in order to get it published. And there's value in being published for a myriad of reasons versus, to me at first, my feeling was you establish the guidelines of how you're going to search for these, and then, okay, you end up with none. Well, that's an answer right there. But is that a reality based publication that will generate interest and will generate money for a study further down the road? I don't know, but I think I really appreciate the fullness of what you elaborated, because it just it harkens so much back to the the kind of contamination of the terminology that we've had to go through as patients, with so much research, but this really helps me see clearer.
But I think what I learned from, the questions that you sent ahead, because that was one of them, was that I think what we could have done differently, and hopefully will with our future publications, is really emphasize that more. Like we do have, but it's like one paragraph, right?
Yeah.
In the discussion about the criteria, the Oxford criteria, and how they shouldn't be used, and about how none of the studies reported on PEM, which the IOM has said is like the most important criteria for MECFS. So I think that, your questions were helpful, because I just went, gosh, why did we not talk about that more? I mean, those are really important points. So I appreciate the criticism.
Well, thanks. Yeah.
And I think that's the part that is so frustrating to patients, is when they go to seek help from clinicians will quickly do their search and find that PEM isn't part of it. So then why are you complaining about this, or why are you documenting, that piece of it? If it's absent, then it doesn't mean that it's not a valuable piece of future research, but it just doesn't transition into practical treatment applications. And that's really frustrating for patients when they're trying to speak to clinicians.
Right. I think we are past that though. Like the Canadian consensus criteria have PEM as mandatory, and the IOM NAM has come out with PEM as the most important. And now the research is moving so quickly. The metabolomics research coming out of the NIH collaborative centers. I think there's a sixth one now. So the 6 centers, like 4 in the US, 1 in Canada, and now a new one in Australia. I mean, they're just really, it's looking very strong that it's a disorder of cellular energy. So I think research from now on is going to be much better. That's my hope. I'm an optimist, otherwise I wouldn't be in the field.
Yeah. I think that's an astute an accurate statement, except that unfortunately, I think at least in the PT world, that the trickle down into that world is going to be slow, and it might translate into maybe a brief conversation with a medical doctor, like, no, be careful with your PEM. Watch for PEM, and then they send out the door. But or they document in the note, patient complains of persistent PEM, but that's where the conversation ends, and they refer to a therapist. And I think the ingrained thought of exercise as medicine. So we see it a lot in our group. People who voluntarily have sought out this group that we're in, and we have some pretty specific questions to join the group that trigger. We're going to be looking at it not as a traditional probably in the traditional model you've been exposed to. And then yet it invariably for many, many conversations loops back around to what are you doing with them for exercise? And not saying that there's never a role and a place for exercise, but they're completely missing that PEM has to be the first and foremost discussion, and all the other, ADLs and IADLs need to be addressed first in that context, and then exercise if appropriate. And so it's almost like, I feel like we're in a zone where the scientists are moving forward, but the clinicians are, like there needs to be a kind of an acceptance or a methodology to make sure that it stays really in the forefront so that they hear this.
Again, just for the purposes now that we're recording, because I mentioned this earlier, but in Canada, we have this nationally funded research team called ICANN CME. So if you look it up, ICANN CME, it'll pop up. And we have a very ambitious agenda, which includes educating all healthcare professionals at every level of training. And so I would be, if any people in your group want to connect with the education group in our, like up in Canada, I'd be happy to connect you. And I think they would be happy to have an OT or PT, maybe even on their committee, or at least as an affiliate member, to make sure that the education they're doing is I myself have been super frustrated over the years with OT and PT, like they're just not getting it. And they could play such a helpful role and they're just not. And I've even said that at conferences. And then of course there's a PT sitting in the front row, right? But I think you are the people who are the best situated to teach people pacing. I've got a webinar on my website called Deep Pacing, and it's just really trying to focus people's attention. Like, this is the single most important thing you can do to manage post-exertional malaise.
Well, because I think pacing is the biggest change of life choices. You have to learn how to prioritize. And, many people they want to be better, but they don't want to, cut out things from their life. And my background is pediatric OT is always been, I've always felt like in the pediatric world, it's so meaningful to me because it's always building skill. Like, these kids are so excited. They're constantly learning new things and everything is so new and fresh. And looking at somebody that has ME, it is the complete opposite, because you're taking away, and like Tatiana you had said, like, it is peeling the onion, and that's what pacing is peeling back the onion to find what the core of your activity needs to be to sustain the rest of your day and week, and planning. Today is not, you're not going to feel better. You need to make choices today so you can feel better next week, when something that's on your priority, that's the core of your onion, is going to be what's so meaningful. And OT, that's our job, is to bring meaning into activity. And it's something that is, I think, really hard for especially people with ME. That is the whole part of the disease, is how do you pace? Well, that's, other diseases don't have to do it to that severe, but the mindfulness of how to pace is, I think, a very big piece that that people are angry about, and they're angry about having to make these choices. But it's complicated, but I feel like that is the hard part about having this particular disease. So,
if I could just add an observation, kind of as an outsider. One of my best friends has ME, and she's had it for years. And I'm always, well, maybe not astonished, but disheartened when I see that she knows how to pace herself. She's been doing that for years, but every once in a while, something comes along and she pushes herself, right? And then she's kind of almost back at square one or square 2 out of 10 or whatever. And like, I've gone through this DNRS brain retraining, but I also teach Qigong, which is a mind-body intervention. And I have a few participants who have fibromyalgia or ME or other conditions. And I teach a couple of classes, and when any of them, or in particular this one friend with the ME, when she has to start back to square one, I mean, I just do individual classes with her. She'll be lying down and using her mind, you know, to help move her energy, and then slowly I see the progression after a couple of weeks or a month, and she can be back in normal class. And it's, yeah, it breaks my heart, you know. Yeah, that's the reality of it.
In the deep pacing webinar, I mentioned like half the webinar is how to pace, like how to use heart rate monitors and all that logistical stuff. But the second half is on the emotions, you know. So I'm a psychiatrist, and I've been working in this field for over 20 years. And that's exactly what I observe. Like, most people are smart enough to know what they quote unquote should do to maintain their energy, but they don't want to. You know, it's not fun to have to be constantly cutting back and missing out on things. So I think unless we address, you know, again, it's the mind and the body work together. Unless we address that part, people won't maybe have as much success as they could otherwise have. Any other questions? I'm just on the paper.
Let's see.
I think you had a question about why anxiety and depression were mentioned as outcomes.
Yeah.
So this is something, I mean, we've had like an incredibly active debate amongst our group for our own study protocol, right? So again, for the systematic review, they're in there because that's what the studies were, right? They all pretty much had fatigue. They all measured it differently, like, again, very low quality studies, but many of them, especially the older studies, had depression and anxiety. So again, we just had to report what was there.
Right.
And it's interesting that, if I remember correctly, the depression and anxiety seem to improve more than some of the more physical measures like fatigue and pain, which is not at all surprising, because mind-body therapies, I would say their strength is probably in some mental health conditions. In our ongoing work, some of our patient partners didn't want us to even mention depression or anxiety at all, right? To just really focus on post-exertional malaise and I don't know what else, like all of the diagnostic criteria for MECFS. But in research, if you don't look at something, then you don't know the influence it might have had. So I think in the end, we decided it's important to at least measure depression and anxiety, so that if people improve with the intervention that we're offering them, we want to know, was it mediated by depression and anxiety? Are the people that improved the most the ones that had more depression and anxiety, and maybe that's what was actually being targeted or not. And if we don't measure it, we're never going to be able to answer that question. So in our study, again, hasn't started yet because we're searching for funding. Our number one, what do you call it, primary outcome measure is actually health-related quality of life. So because that's like overall. So are you able to do more stuff now than you did before? And it's a measure that's used increasingly in lots of research in lots of diseases. So that's going to make it really good for kind of comparing to other studies, which is important. Like you can have an amazing measure, but if nobody else is using it, it's kind of useless because nobody's going to understand what your study means and they're not going to be able to compare it to other studies. So in the end, we decided to go with that as our primary. And then our secondary measures are all the diagnostic criteria, including post-exertional malaise. And I believe depression and anxiety are in there. And I think we're doing something very basic like the PHQ and the GAD. Is that right, Tatiana? I don't have our protocol in front of me.
Yes, that is correct.
Okay. So again, very active debate, but we decided it's better. Like if we show that mind-body therapies only work in the context of mental health, that's very important. And then we're not going to be making recommendations to give it to people with ME that don't have mental health conditions, right? Yeah. Which is, I think, an error that a lot of the previous research has made. I think they've really, it's been a gray, fuzzy zone between mental health and fatigue.
Yeah. Are you also using the DePaul scale or any of those materials?
Well, for post-exertional malaise.
Okay.
Yeah, because one of the things that this is kind of out of left field. I mean, I know you can't do anything with it, but I'd like to hear your thoughts on it anyway. Is there's at least one case example out of Workwell, and I don't know if there's more, but they have a situation where a woman had done the 2-day CPET and was classified as disabled, started receiving Social Security benefits and private disability, and then a year and a half later, during that time, the year and a half, she had very gradually begun her own walking program. And a year and a half later, she felt so good that she went back to Workwell with the presumption that she was going to do the 2-day CPET and be declared undisabled. And when Workwell redid her test, she was 20% worse than she was.
Wow.
Than her perception was. And so I don't, there's not a lot of study out there, obviously, showing that, but that's one of those things that, when I hear the stuff and I've lived with this long enough where I've had moments where I've completely done that to myself, where I've been like, oh yeah, I'm better. And then, the full blown crash happens, and it's, so that's one thing that, how to, I mean, you can't do everything with a study, but yet, to have your thoughts that, how are we capturing that if it is capturable? And
I think that's such a good point. It's one of the criticisms that has been leveled at me by some very opinionated patient partners, say about my online class or my work in general, is that are people actually getting better? Are they just coping better? Or are they perceiving that they're better, but really nothing has changed? Maybe they've learned to manage better, and so they're feeling better on a daily basis, but their biology hasn't changed. And I think that's a really legitimate question. And I think for me, because I've had ME for 31 years, so I got lots of experience of falling on and off the bandwagon. Many times I think I'm cured of something, and then it hits me really hard unexpectedly. What I would say is So again, with Dr. Vora's kind of careful progression of our research agenda, now that we've done the systematic reviews and we know that there's a little tiny, I would call it a glimmer of evidence that mind-body approaches might be helpful. That's about as strong as I think we could make that statement. Our next step is what we're calling basically a pilot study. And the pilot may or may not have enough funding to do objective measures, but our end goal is to do a multi-center randomized control trial with objective measures. And the measure we're most interested in is brain imaging, partially because we live in Calgary that has like a really, prominent mental, like a neuroscience and mental health institute with very fancy brain imaging capabilities. So it's available to us if we can get the funding. But even like we're applying right now for to do a pilot. And if we get the funding to go ahead, we're going to be working really hard to try to leverage that to get additional funding to do at least some objective measure. Because I mean, that's the biggest, I'll say, failure of the research to date is there's almost no objective measures, right? And people can say they're better. Oh, I have more energy, I have less pain, but is it really, has their body changed? Like we need a way to measure that.
Yeah.
And has it lasted? That's the piece of it. Yeah. The patients have done the programs. They're told kind of in order to exit the program, you have to be better. So just like, okay, well, get me out of here. Yeah. I'll tell you it's better. But then do they actually maintain and do they have, improved quality of life scores at the end or 6 months or a year out? How well can those interventions be carried over at home? So yeah, there seemed to be a lot of long-term like follow-up and really figuring out if this is a reasonable treatment or process that they can carry over.
And is it going to have long-term benefits? Absolutely.
Yeah. Because my daughter has gone through twice now a rehab program, one by choice, one by force. And it really made it so visible to me that she was just saying, get me out of here. I will tell you anything. And so then, I mean, she already knew what was going to make her better. So by saying like, okay, I'm going to pick and choose from those programs and I'm going to get some of the benefits, but the physical activity is not going to make her better because obviously they're treating it as deconditioning. But, she did, by being able to pace and learn some strategies, those are things that were very beneficial, but it's just the piece of, how much of that is being followed by research facilities as really documenting it, because I think 99.9% of the ME patients will say just doing those type of programs will not be followed, and the clinicians do not know how severe and how damaging those programs are a month or 2 months or 3 months down the road.
One of the objective measures, I'm sure you guys have covered this, but it was kind of an eye-opener for me. We had Mary Demick speak with us about writing for disability for,
Oh, nice.
Yeah. And she brought up the typing test, which I thought was a really nice idea because it would capture cognitive and physical performance, and it captures PIM, and it's short, so it's not like the CPET where you're quite as worried about some of the lasting, there is the issue about that, and it would be inexpensive. So that, if the funding doesn't come through for some of the more sophisticated stuff, option.
Of course, we're hoping for so we have, we've been networking and we have all these wish lists. So one of the, we're looking at maybe some mitochondrial testing or something.
Yeah.
But in the long, for our big study, we want it to be brain imaging, because that's really the bottom line. Like, did the brain, we're doing a mind body therapy. So did the brain change or not?
Yeah.
Yeah. I'm just noticing the time. I think Tatiana has to leave pretty promptly, right?
Yes, I have a meeting with my university students to work on their research study.
Awesome.
Well, this was an awesome conversation, and I think I really appreciate you taking the time to meet with us and bounce these ideas. I think the thing that just sharing with us the kind of the mindset behind how you guys approached it really helps a lot. And as you well know, those of us that are dealing with this, probably look at this stuff in a 1,000 paper cut sort of the world. And so, but I think that's also important to take into, how the paper's written, not just the research, but how it's written. Because I think you guys, it'll be a great platform for, not just conveying the information, but making inroads into the kind of numbskullery that's out there. And
yeah, thank you for, I really appreciate it and was pretty wowed by the detail of your feedback. And for me, like, I'm keeping this because it's really does highlight things we need to be really, I think, more aware of when we're writing up our results. If we're so fortunate to be able to actually do our study.
Yeah, definitely. Well, please let us know if there's anything we can ever, do if our group, and obviously we're in connection about pathways to improvement, but be in the loop there.
Okay, thanks so much.
Yeah,
Yeah,
nice
thank
meeting
you. Thank you so much.
Nice meeting all of you.
And good luck to your daughter, Amy. That sounds pretty rough.
Yeah.
Thank you. Yeah, it's a slow process, but we're moving. We're getting there.
Okay, that's good. Bye-bye.
Thanks. Bye-bye.